I want to thank you for inviting a podiatrist to this meeting. You know, we talk about allopathic, osteopathic, podiatric medicine. We all work for the same people at the same hospitals. We're all on the staff together. Many of us trained together. I did my residency at St. Vincent's Medical Center over in Jacksonville, so I know a lot of family practice physicians who've moved on to DPC also, so it's actually been really, really good. I'm going to do a little promo here. I just wrote a book. It was so out of place for me to do that and out of my wheelhouse, but it's out there. There's these little things, bookmarkers with a QR code, because I really do think if we had known all this stuff when we were in school, we wouldn't be in the predicament that we are. We would know how to manage around it. So thank you again for having me here. And a little bit about me. I'm blessed to practice in Pensacola, Florida, the Gulf Coast. It's a little warmer there right now than here, where I grew up. I'm Brooklyn born, but my parents moved us there when we were younger. I am second generation physician. I have an internist mom and a general surgeon dad. They're envious of my schedule as a podiatrist. I didn't have the long hours, but I got the best of both their worlds, both the chronic medicine and also surgery. They practiced during the heyday of medicine from 1964 until they both retired in 2014, 2015. And they cannot believe what has happened to medicine. Today, I still get to practice with them. They volunteer twice a week at volunteer clinics in the community. And because of the way that I set up my practice, I have time to volunteer with them as well. So it's actually been kind of fun. But the doctor-patient relationship, this is the essence of clinical medicine. And Jeremy, I'm sorry, is this a touch screen?
Space bar will advance.
The space bar, okay. Okay, got it. So I think most doctors understand the frustrations that we all have these days, the paperwork, the pressures to see more patients, questioning by non-medical personnel about things regarding your patient, coding and compliance, and just the exhaustion of trying to get authorizations and just get everything done and get home also. Like Dr. Huntoon said, that was me in 2013. And I came to an AAPS meeting here in Dallas that fall, and after receiving a random email a couple weeks prior to this thing called How to Thrive, Not Just Survive. And it was a one-day conference, quick, easy way to get CMEs. I went to it, you know, in addition to the frustrations I stated earlier, we were anticipating even more changes as Obamacare had begun to become legislated, and the healthcare.gov website was about to start that new exchange. None of us knew what was going to happen, and I don't know if you remember then, the first day that website went on, it actually crashed. So that should have been foreboding already as to what was going on. I honestly didn't know what to expect at the meeting or what I would learn, but I kept a really open mind. My first lecture was Dr. Huntoon's lecture on how to opt out of Medicare, where I learned what the Medicare law actually said and the difference between theory versus reality, and immediately I was hooked. I was drawn in and ready to hear about more because I never even knew that there was an option of not contracting with insurance. I met so many amazing docs who were doing that there. I'm so happy to see so many of them again. Dr. Held was there, Beth Haynes, I don't know if you all remember her, Keith Smith, Josh Umber, Kathleen Brown, Gerald Giannoli, Dr. Ammerling. And I still keep in touch with them, but they were so amazing, they were encouraging. I came back from that conference very motivated and began a three-year transition, dropping what we love to call the BUCAs, which are all the commercial insurance companies, Blue Cross, United, Cigna, Aetna, and Humana. I dropped all the other commercial ones first, and then dropped out of Medicare January 1st of 2017. So to come here and speak to you all 10 years after that introduction really comes full circle for me. So again, thank you very much for that. Back in 2013, practicing medicine was becoming increasingly frustrating. for most of us, it didn't start that way. We always loved what we were doing, the clinical aspects. Like was said, I started my practice in 2001 and still had paper charts. I complied with all the initiatives. However, I noticed each one of those new initiatives were almost like a big brother thing that had nothing to do with the clinical care of practice, more barriers put between me and my patient, daily pre-authorizations. You guys know all this, for procedures, for prescriptions, compliance rules, claim denials, each year an enticing incentive that became a penalty if you didn't comply. And then they had these quality measures, because that was all during the PQRS stage of Medicare. But quality according to who, you know? And then, and we can't forget, reimbursement rates. They were constantly going down. And so to make ends meet and to get past those reimbursement woes. I try to do these slides to make it interesting and have these transitions, and sometimes it backfires on me, so apologies. You end up seeing more patients, and an overbooked schedule of like 25 to 30 patients. It's just, you can't do it. I had to see those patients. You couldn't really do the charting, and you would bring home all that homework at the same time. Medical economics came out, and they come out every year with an annual survey. What's ruining medicine for doctors? Overwhelmingly, every year it comes back, third-party interference. And the problem was that these administration rules had nothing to do with clinical practice. From a podiatrist perspective, I'll give you a couple of examples here. Bilateral toenails, ingrown toenails, insurance typically would only pay for one. You would have to bring that other patient back in order to get the other one paid for. You know, if as a surgeon, when I'm doing a 4-foot surgery, bunion and a couple of hammer toes, you get paid for the first procedure, the bunion, and then the second, third procedures, it's half, and then a third, and then a fourth. I don't know if people realize that. And then last, I call this diagnosis discrimination. Everybody is familiar with the diabetic foot and all of its risks associated with pressure points, creating ulcers that eventually can become infections. The problem with that is, you know, Medicare will cover the criteria if you need a diabetic shoe and you're a diabetic. But if you have that same foot and you have it because you had a stroke and can't feel anything, or if you have rheumatoid arthritis and you can't, and have like really bad arthritis, the special shoe is not covered for them. So it's like you had to be sick in order to get a shoe covered for them and protected. You know, in all those instances, I just swallowed the cost of it for the patient. I didn't, you know, in my reimbursement part, because, you know, clinically I knew I wasn't going to get paid for it, but I slept well at night. I was able to do what was right for my patient, because it's always about that relationship you have with them. And, you know, you think about it, why'd you go into medicine? For the most part, all of us did it because we wanted to help somebody, and we do that in the auspices of the doctor-patient relationship. But that clean connection was becoming disrupted. The intermediaries were becoming more and more, and they were beginning to instill more influence over the whole system. Direct care is so clean, it's so pure. In my office, the patient finds me, they call my office, they make an appointment, they come, I examine, diagnose, and treat. They pay for the services at the end of the visit. Done, that is it. It's great, I get my notes done. Unfortunately, most people, most physicians and patients don't know what direct care is, and that means we've got a lot of work to do. It's all about education. My mission these days is twofold. I take care of the patients who entrust me with their care, but I also am big about educating physicians and patients about free market medicine. I found that collaborating and messaging with the patients is the most effective. I talk to them. I stole this from my, I have a lot of teachers that I see, and I use the analogy of education, actually. It's a very clear example, and people understand it. So think about public school versus homeschool. Liken it to insurance-based practices in direct care, what's available for patients. We all pay local taxes. for public school, but there are parents who choose to send their children to private school. It's their choice. Keep in mind, the majority of my patient base, the majority of most of your patient base is going to have insurance, but the patient should have that choice to seek alternative choices. And when that patient values you as being what they want, you can't beat that kind of marketing. And that is the best thing. You can't pay enough to get that kind of marketing. It has to start, though, with us. Then we spread it to our patients, and then out from that, it will begin to expand. But, there isn't a doctor out there. We have to get the doctors on board, and there isn't a doctor out there that wants to think that they've been had by the system. So the question always becomes, how did we get like this? And the thing is, most of us didn't really see it coming. We had too many things to worry about. Our schooling was so regimented. Our training was regimented. There was a lot to do. We learned how to see one, do one, teach one. We learned to accept things the way they were. We were conditioned to conform. And at the end of residency, what was it that they tell you? You have to get on insurance plans or else patients can't see you, they can't find you, and you won't get paid. And when it got time, when we got out on our own, we were presented an insurance contract, and what did you do? You pretty much followed and you signed. And the thing is, early on, the first 40 years probably, last 40 years, the majority of us didn't really see the problems going on. There was some irritation, but we didn't realize what was happening around us. And for a profession that talks so much about informed consent, we were not given that. And as we followed and continued to practice clinical medicine, the business of medicine changed around us. Patients no longer sought out doctors directly. Physicians were referred to as providers, and provider networks and maintenance organizations developed. Middlemen and intermediaries became the norm, and with every new rule, regulation, and directive, doctors started hearing terms and started having to do things that had nothing to do with the clinical care of our patient. And, we've all heard third-party payers and insurers say they need to run things better because they're trying to cut costs. And it will avoid additional spending, and it can create better healthcare outcomes, really. You have to understand that they've been touting this message for decades, but the facts tell a different story. Healthcare costs and administration have exponentially grown, and if you see that little blue line at the very, very bottom, that's physicians. It is almost flatlined. So as physician colleagues leave medicine, burned out, not wanting to continue on, who do you think will be treating patients? The administrator, the reimbursement specialist, the claims adjuster? Administration's important, but there's no health care without doctors. But the bad thing is that it's also affecting patients, our patients. And an article just this past August in Business Insider noted almost 70% of bankruptcies in the United States is tied to medical debt with those individuals who have health insurance. Axios yesterday had an article that reiterated that also. So when you think about it, it's been so insidious. Doctors and patients, we didn't see it coming. It's a game. It's a game to the whole third-party payer industry, and they're playing both sides. So from the doctor's side, they offer you a chance to be in their network. They've conditioned everyone to thinking that if you have insurance, that you can only see their providers. And they have rules to follow. Your contract package includes fee schedule for reimbursement, but that fee schedule, they're telling you what they are going to pay you, but they are also determining your price and your worth with no regard to the local costs that you have for running your practice. Oh, and we can't forget the payment schedule. They determine how long it takes for them to pay you once you've sent in the claim. They also set the rules on deadlining or filing that claim, and they also set the rules on the opportunity to take back the money from you. And that's just the doctor's side. And the patient sides, they collect an annual premium, which keeps going up. They set the deductible, which determines the threshold before they pay. and begin to pay. They rule on prior authorizations and determine medical necessity, and then they say that they'll cover a portion, like 80-20. But 20% of what? No one knows the prices. So education of physicians is important about this, and educating patients is essential about this. And it's so essential because the whole system is a bunch of misaligned incentives. It has a detrimental effect on both physicians and patients, and it's not healthy. First, do no harm is a Hippocratic tenet that we all are familiar with, but how effective can we be if we don't protect ourselves? And as we know, when the doctor suffers, our patients will suffer, their experience suffers, their satisfaction, and unfortunately their care. And you guys are all hearing that. My insurance didn't cover the prescription you wrote, or it's gonna take 4 months for me to get in to see that doctor you referred me to. Or I can't go to that facility, that center's not on my network. Care like that becomes fragmented, it becomes reactive rather than proactive, and there is no preventative care in that. And it makes you wonder, are we really then promoting sick care? So remember, insurance companies are beholden to their shareholders. They'll push volume over value. They'll count the number of services with no regard to need or quality of the result. But doctors are beholden to the ones they are treating, our patients. But if you are not out of that system, when you're contracted with insurance, you have to abide by their rules. And because you are not paid directly, but indirectly, the reimbursement is typically not equivalent to the actual cost of the visit. And how can it be? The insurance company sets the allowable rate, but they don't take into consideration, again, the local there. Remember, the insurance company is going to determine how to pay you, what to pay you, when to pay you, and if they will pay you. And without that ability to adjust the price based on your community and your market, you have lost all the forces that you have and your assets that you have to work with supply and demand, the economics of the local. Remember, most people can't function 3 to 6 months without getting paid. Most offices can't do that. And I don't know about you, but I would like to dictate where my charity goes to rather than being told by the insurance company what write-offs I have to do. So when doctors need to remember that our skills and knowledge have worth, it's valued. We took a Hippocratic oath, we didn't take a vow of poverty. And think about it, when you call a plumber or look for a mechanic and even other professional services like accountant or lawyer, you find who you want, you work with them, you hire them, the service is completed, prices are transparent, and payment occurs at the end of the transaction there. That's how business works, but that's not how the norm is in medicine. And when you're contracted with insurance, there is no way you can have that direct relationship with your patient. When you don't control the process, someone else is going to call the shots. It's inefficient, and think of all the little bottlenecks that can occur. In insurance-based medicine, that's coding, authorization, reimbursement, and scheduling. Look at the revenue cycle. Once a claim is sent to be submitted, it is out of your hands, and you're at the mercy of the third party. And the thing is, it's not just at the claim submission part of the cycle. It can also occur before billing occurs when you're trying to get authorizations. When that MRI facility tells you that you need to get a pre-auth for your patient, why is your office doing the authorizations? You don't work for the facility, or an employee that you pay must do the additional work, and you're not going to get paid back from that service. Ask yourself, are those places reimbursing you? Direct care, it is so clean, it's clear, it's straightforward, and fully transparent. All parties know what's going on. It avoids the cash flow lull and uncertainty and removes inefficiencies. It saves resources, your time, your staff's time, and your patient's time. Remember, it's not the doctor, it's not the patient, it's the system. For me, I knew it was not something that I wanted to stay in. I didn't have a chance of being able to control anything then. It was a system that I didn't have to, and none of you have to practice and participate in, just to do what we love to do. So I opted out. And so for both physicians and patients, while you can't control the environment you're surrounded by, you can control how long you stay in it. How I transitioned, it didn't happen overnight. I was very methodical, I was strategic. I took my time to talk with my staff and with my patients. I paid close attention to numbers, to balance known expenses and expected revenue, most importantly, to sustain and maintain cash. In 2016, I averaged 26 patients a day, working 5 days a week. My actual reimbursement rate was 61%. That's 61 cents to every dollar that we were charging versus now 10 to 12 patients a day, 3-day weekends, and I get 94% of what I charge. I learned to work smarter, not harder. You can do that too. In my office, what happens is there's no checking for in-network. We tell the referring physician and send the referring physician, tell them, let the patient decide. My prices are all transparent. They're all on my website. And if there is something that's not listed, we always quote it ahead of time. Most of my patients have insurance, and they can get reimbursed. We give them a super bill at the end with a receipt. If they have third-party commercial insurance, many of them have out-of-network benefits. We encourage them to do that. But the thing is, my office doesn't have to deal with that on the day-to-day. I determine what's medically necessary and don't need to ask a third party. And perhaps the best benefit of direct care was that it was COVID. It was COVID because it was adaptable. It was pandemic tested. Everything shut down. Telemedicine was not new to us. We were in contact with the patient all together. I would do home visits for them. There was continuity of care. The thing with specialists, they always say, can a direct DPC model work in specialty? Absolutely. When you hear DPC or sometimes DSC, direct specialty care, it's just semantics. It's all direct care. Most definitely we can do this. And when you think about it, we're all practicing primary care when you're outside of the hospital. The Oxford defines 5 points. Preventative care, I do that when we're talking about prevention of diabetics and complicated issues there. We see common illnesses. I can perform those early enough to protect patients from cancers. We can check for lesions that could potentially change. I manage chronic conditions, especially those with metabolic diseases like the rheumatoid, the autoimmune. I do that in conjunction with other specialists as well. We look at chronic conditions like bunions and hammer toes. And we refer and coordinate and collaborate with physicians in the community, other specialists, the vascular surgeons, the rheumatologists, and even the other specialists called family medicine, internal medicine. Think about it. There is no primary care specialty. It's a designation, and ironically was started by the insurance industry. So for me, when you change how you interact with the system, the differences are so apparent. Patients can go to doctors directly. Doctors can treat patients directly. When this happens, doctors can do their job and do it better. Patients get better care. It's care that can be focused on prevention. It's proactive rather than reactive. It becomes affordable because there are no other players in the mix. Price transparency gives patients the opportunity to budget and review things. This fosters increased communication, better availability, better accessibility, and this is what you want, and this is what your patient wants also. And before I end here, I want to make sure that people understand this is not a bash health insurance lecture. Whether you're talking to doctors or patients, it's not an us versus them thing with the insurance companies. The ecosystem that we are currently in did not happen overnight. Health insurance is a financial risk management tool. It was never meant to be used the way it's used today for routine and non-catastrophic things. We know that with home insurance and we know that with auto insurance, but we need to emphasize that healthcare does not equal health insurance. The problem is physician autonomy and patient independence. That's what we need. And by controlling both parties, the insurance industry has been given way too much power, and have too many conflicting responsibilities. They control the power there, has inadvertently removed all the market forces from the system. So in my opinion, an independent private practice will not be sustainable under the current insurance-based model. For me, I found a way to practice that works directly with the patient. I didn't change how I practiced medicine, I changed how I interacted with the system. And everyone here can do it. Moving forward, how do we do that? You think about what's holding you back, be strategic, analyze your current practice, know what you want out of your practice. You really need to create a mindset, get your staff on board, get your patients on board, and discuss with other physicians. The majority of my patients have insurance. It's not that they're going to stop having that insurance, but now they learn how to shop. I explain this, I explain the advantages to them, and I anticipate all the questions that they have. The beauty about direct care is that the patient, all they need to do is just ask, what's your cash price? Remember, there's no template, and you're not alone. Don't be afraid to ask. Go to organizations like AAPS, FMMA, go on social media, find podcasts to listen to, conferences like this, and find a mentor. And I want to again thank you for allowing me to speak today. This parting shot here is from Pensacola. This is the famous Blue Angels, the Navy stunt team. They are based out of Pensacola. One of my high school classmates happens to be their official photographer, so I'm allowed to use this for them. And the homecoming show is next week. So at any rate, thank you again for having me.